Hi, we're back at the annual meeting of Women's Cancer, the Society of Gynecologic Oncologists, and we're joined here with an expert in cervical cancer and HPV, and I'll have him introduce himself.
Thanks a lot. My name is Warner Huh. I'm a GYN oncologist at the University of Alabama at Birmingham, Alabama.
We're very interested in what are some of the differences internationally versus what's happening in the U.S. The U.S., we're starting to finally get a little more understanding of what HPV is in the general population. People are starting to adopt not at the numbers we'd like, but adopt the HPV vaccine and understand screenings. How does that differ as we move internationally in Africa, South America, and developing and underdeveloping countries?
You know, when you look at developing and underdeveloped countries, you know, they don't have the money and the infrastructure to rely on things like pap smears. And so I think for them, in order to incorporate a cervical cancer screening strategy, it's going to have to be molecularly based. And what we mean by that is incorporating HPV or human papillomavirus testing. And the reason that's better for them is that they don't require a special technician or a specialist to read the pap smear. And there's actually ongoing studies now where you can do in-field testing, where you test a woman for HPV, you'll know your answer in 5 to 10 minutes, and then make a potential decision about to treat them right then and there. Because there are two components to reducing cervical cancer morbidity and mortality. One of which is the screening part of it, but two is the treatment part of it. And you need the two of them are tied in very close to one another. But the ideal circumstance would be to have a woman come in, get tested, get a result immediately, and then get treated immediately as well. And I think that's how you affect a very palpable, significant decrease in cervical cancer rates in a developing country like in Africa or even Southeast Asia. So.
Are we learning some of the numbers we see, especially of cervical cancer occurrences in some of these underdeveloped countries, are amazing and sad in cases? We learning things about the HPV virus? Are there different strands that are active in different areas of the world?
Right. So there are classically 14 what we call high-risk strains of HPV or types of HPV. And they're called high-risk because they're clearly associated with the development of cancer. But leading that list is clearly type 16. Which happens to be in the vaccine. And this is the reason why it's in the vaccine, because one is, not only is it the most common type, not just in the U.S., but worldwide, it's also the most virulent type. And we know that women who are persistently infected with 16 have a much higher risk of developing a severe lesion and even cancer over their lifetime. Now, depending on where you go, type 18, which is another common type we see, might be second on that list, but it varies from region to region of the country. But the common thread here and theme is that 16 is by far and away the most common type, but also is the most virulent type as well.
What are some of the things that are being done that you know of internationally to, one, start tests of the trials of HPV DNA tests and things like that, and also then from screening, also are there vaccination programs that are happening in developing countries or other things that are happening to limit the spread of HPV and catch cervical cancer early?
Right. Well, so like I mentioned earlier, you know, I think more and more countries are very invested in using HPV as their central platform for screening for several reasons. One, we talked about it's automated, it's easier to do, you get a yes or no result, it might be immediate, and it could potentially be cheaper. And I think in a lot of developing countries, you may only have 1 or 2 shots to screen a woman in their entire lifetime. So what makes sense is you got to make the most of it. And I think that's where HPV makes sense. Regarding vaccination, I think if we lived in the perfect world, like if you saw with, for instance, polio or, you know, smallpox, if we actually had the ability to vaccinate everyone, irrespective of cost, I think in many ways it would have such a tremendous positive impact on screening, because you may not be able to screen, you may not have to screen so often. But the issue is really, unfortunately, is the cost of the vaccine. That's one major hurdle. The other hurdle is obviously that you have to have 3 shots. So an individual child, girl, or woman has to come in 3 individual times, and I think follow-up is a big deal as well. So I think there are a lot of logistic issues. We know the vaccine works, and if you administer it, it works on a population-based level. Case in point would be Australia, because they have one of the highest penetration rates for vaccination in their country, and we're already seeing dramatic rates of drop of things like genital warts, and we expect the exact same thing with precancerous lesions. But I think in order for the vaccine to have an impact, I mean, I do ultimately think that we need to have a cheaper alternative, and I think that we also need to have the ability to potentially even to maybe just vaccinate once so that we don't have to worry about patients coming back. I think we're getting there, but what's most important is that clearly the science demonstrates that these vaccines are highly efficacious.
What do we think, Dr. Howe, what do you think are some of the, in the near future, next 1 to 3 years, that'll be the biggest impact on the international HPV, cervical cancer, HPV-related cancers? What will make the biggest impact? What are some of the scientific breakthroughs? Is going to be the...
You know, there's Merck, who's the maker of the quadrivalent vaccine called Gardasil, they have a 9-valent or 9-type vaccine and being currently tested in clinical trials. And that covers roughly 88 to 90% of the types that cause cancer. If that vaccine proves to be effective and protective in women, that is a true game changer, because, you know, if you potentially vaccinate a girl and we can show that the vaccine lasts for a long time, you might be able to make the argument that women may no longer need screening. So instead of focusing on screening with pap smears or HPV, the focus automatically then switches to vaccination, less about screening. And I think, again, that's a classic example where that's a true paradigm shift for women's health care that we've never seen before. I mean, and I think I really do fully anticipate that that vaccine is going to really raise some interesting discussions about where do we put our monies. Do we put it towards cancer screening or vaccination and prevention measures like that? So I think it's going to be a very interesting discussion. So,
last question. For organizations that are doing relief efforts, health efforts in developing nations, when they're dealing with cervical cancer, HPV, what would be your personal opinion and suggestion of some of the first things they should do to start, whether it's screening or testing or vaccinating? What are the first things they can do to help, let's take, in developing countries where the numbers and percentages are so much higher of HPV and cervical cancers and dysplasias and all that?
Well, I mean, I think ultimately, with all countries like in that situation, you know, unfortunately, cost and its relationship to effectiveness becomes the first issue. And I think that, you know, unfortunately, they may not be able to individually model a screening system off of another country because their country is so radically different in terms of the population, perceptions, barriers to access to care. But I think that people have to look at really what, number one, is going to be the most cost-effective method of screening, and then figure out when they're going to do it and how they're going to treat those patients. And I think that each individual country has to look at that, because it's just impossible to mirror image a screening program off of another country, particularly a developed country, because the resources are so radically different.
Great. Thank you very much, Dr. Hunt. Thank you.